So today I'd like to talk about the basics of atrial fibrillation ablation, which is the primary procedural modality for treatment of atrial fibrillation, which is the most common human arrhythmia. Now I'm going to take you through a slide set that will explain what atrial fibrillation is, how we manage it in the modern era, and what to expect from an atrial fibrillation ablation procedure. First, atrial fibrillation is the most common human arrhythmia. It's estimated that anywhere from 6 to 20 million people may have atrial fibrillation by 2050. We have an aging population. Atrial fibrillation is very much a disease of aging. It increases in incidence with every decile of age in an exponential fashion. And it is by far the most common arrhythmia that we manage as cardiac electrophysiologists. Unfortunately, the medications that we have to treat atrial fibrillation are not very effective. The most effective drug that we do have is amiodarone, and it's only about 50% effective over a course of a 5-year time period. And you see these graphs from studies that were done several years ago. Amiodarone, being the most effective drug, is actually also the most worrisome drug with regard to side effect profile. It's a drug that can cause lung, liver, or thyroid toxicity. So we really only use that drug in exceptional circumstances and where we're having to treat atrial fibrillation for relatively short periods of time, if we can avoid it. The other drugs, so-called class 1 drugs that you see here, these are drugs such as flecainide and bupapanone, are less effective than amiodarone. Another drug, sotalol, and its sister drug, Ticasin, are also less effective than amiodarone. So there was a real effort to try to find better ways to treat atrial fibrillation. And a landmark clinical trial was published in 1998 by a group from Bordeaux, France, led by Michel Hasseguer. Most of us who have been in the field for a long time, I've been doing this for close to 25 years, remember where we were when we read this paper. This paper was published in the New England Journal of Medicine in January of 1998. And it was the first to define exactly where atrial fibrillation was coming from. The old concept was that atrial fibrillation was sort of a general abnormality of the upper chambers of the heart. But Dr. Hasseguer and his group demonstrated that the atrial fibrillation was really a more focal problem in most people, and in fact originated in the pulmonary veins. From their paper, what you're looking at here is a schematic that shows the two upper chambers of the heart, the right atrium and the left atrium. I'm going to demonstrate in another slide here in a few minutes just exactly what that anatomy looks like. But you can see here that Dr. Hasseguer and his group were able to demonstrate that if they took patients into their electrophysiology laboratories and distributed electrical catheters throughout both chambers of the heart and waited for an episode of atrial fibrillation to occur, and mind you, these were all patients who were going in and out of atrial fibrillation on a daily basis, they were able to identify that in 94% of their cases, the atrial fibrillation was originating in one or more of the pulmonary veins. Those are the big blood vessels that bring blood back into the left side of the heart from the lungs. And this is a view of the heart looking in from the back. If we could put a camera in and look through a person's back and look at the back wall of the left atrium, what you see here are 4 big veins, and I've got some red markers there that illustrate where the atrial fibrillation originates in most people. Those are those pulmonary veins. As it turns out, when humans go through fetal development, we generally deposit some heart muscle tissue out along these veins. As the heart forms and the lungs sort of bud off from the heart, a lot of us deposit little strips of heart muscle tissue out along the pulmonary veins. And at some point in life, sometimes it occurs as early as in our 20s, but more commonly 50s, 60s, 70s, this muscle tissue that's sort of in a way we can think of it as misplaced will start to fire rapidly. And it's that rapid firing from this muscle tissue in the pulmonary veins that is the triggering mechanism for atrial fibrillation in almost everyone. And here we see an EKG that demonstrates what atrial fibrillation looks like. At the left-hand side of the screen, you see a little burst of atrial fibrillation, that very irregular rhythm, and then a normal beat, and then another burst of very irregular cadence on the EKG. And that's the hallmark feature of atrial fibrillation. Atrial fibrillation we refer to as an irregularly irregular rhythm. And as such, it causes the heartbeat, the pulse rate to be irregular and quite chaotic. So this is a view of the anatomy of the heart. And I really want to point out here both the structural anatomy and also the electrical anatomy, so that we can then discuss what atrial fibrillation is and how it affects the heart. You can see here that the heart's a four-chambered muscular pump. We've got the two upper chambers of the heart, the smaller upper chambers, those are the atria, separated by valves from the larger pumping chambers down below, the ventricles. And if you see on the left side of the screen here, there's a nest of cells shown up on the upper right-hand side of the heart. That's called the sinus node. The sinus node is the heart's intrinsic pacemaker, and it generates the electrical current that then flows through the muscle. And it's the flow of electrical activity through the muscle that causes the heart to contract. So the sinus node, when we are in a normal heart rhythm, generates the electrical current that initiates the heartbeat. That electrical activity passes from cell to cell through the atria, making them contract. And then that same flow of current passes down through specialized heart muscle tissue that almost acts like a nerve, the atrioventricular node that you see in the mid part of the heart here. And that branches then into the right bundle branch and the left bundle branch. And that's how that impulse is carried down into the ventricles. So in this situation, when we have what we call normal sinus rhythm, that's the normal electrical activity of the heart, the upper chambers and the lower chambers of the heart are beating in sync. And that's the most mechanically efficient way for the heart to work. The sinus node, the heart's intrinsic pacemaker, is exquisitely sensitive to adrenaline. So the heart rate can change depending upon how physically active or emotionally stressed we are. But that pattern of current flow should stay the same. Now, when we go into atrial fibrillation, what happens, these upper chambers, these smaller upper chambers of the heart, start beating very rapidly. They're beating as fast as 350 times a minute. And when they're in that state, the upper chambers are not able to push blood down into the lower chambers effectively. So we lose some of the priming activity of those upper chambers of the heart. And it causes those lower chambers, as you saw on the EKG earlier, to beat rapidly and irregularly. And that combination causes fatigue, shortness of breath, palpitations, sometimes dizziness. And so those are the hallmark symptoms and features of atrial fibrillation. The other thing that occurs when those upper chambers are fibrillating is that the blood tends to pool. And in particular, you can see on the right side of your screen here, there's a little outpouching of the left atrium. It's called the left atrial appendage. And when the heart is in fibrillation, that's an area where blood flow tends to be particularly static, and clots can form in that location. And that's the reason that we use blood thinners for the treatment of atrial fibrillation to prevent stroke risk. One of the probably the most worrisome complication of atrial fibrillation is the potential for a clot to form in the heart in a patient who's not anticoagulated, and for that clot to dislodge and then travel through a blood vessel to the brain and block a blood vessel in the brain and cause a stroke. It's one of the common causes of stroke, and it's probably the most feared complication of atrial fibrillation. So how can we manage this? We've talked about how the pulmonary veins are the bad actors in atrial fibrillation. Once Michel Hassaguer and his group in Bordeaux made this discovery that atrial fibrillation was more of a focal problem than a global disorder of these upper chambers of the heart, we began to design procedures to try to electrically disconnect that abnormally firing heart muscle from the rest of the body. And in the early 2000s, we began to do what's called ablation therapy for the treatment of atrial fibrillation in increasing numbers around the world. We had already had ablation techniques for more simple arrhythmias, supraventricular tachycardias, little electrical short circuits, most commonly in the mid portion of the heart. There's an rhythm called AV nodal reentry that we have been ablating since the early 1990s. But again, once we discovered where the AFib was coming from, we began to apply these techniques to the pulmonary veins, because we understood that if we could electrically disconnect those sort of rogue areas, that rogue heart muscle tissue from the rest of the heart, we could effectively treat atrial fibrillation. And there were several early studies that demonstrated that ablation could be very effective for the treatment of AFib, and in fact, more effective than any of the drugs that we had. So fast forward to where we are today. When we bring a patient in for ablation of atrial fibrillation, we use multiple modalities to put our catheters in and create these lesion sets that will eliminate atrial fibrillation in the majority of people. And this is just a view of the computer screen that we as electrophysiologists during the course of an ablation procedure are looking at when we endeavor to place the catheters precisely and put in our lesion sets that will then disconnect this abnormal electrical tissue, this abnormally firing tissue from the rest of the heart, and thus treat the atrial fibrillation. And there are several images that you're seeing here. This is a static image, but we're seeing this in real time as the operator. We're standing on one side of the patient who's under general anesthesia, lying down on the table. We have catheters in the heart. You see that on X-ray in the lower left-hand corner here. And those catheters have been very precisely placed with X-ray and ultrasound guidance. You see an ultrasound image on the upper left-hand side of the screen. And then the real magic, I think, in atrial fibrillation ablation is what you see in color, sort of right in the mid-portion of the screen. That is an electroanatomical map of the heart. And this is one of the major technologies that's been developed over the last 20 years for this purpose, for very precise localization of catheters in the heart, for an evaluation of the flow of electrical current through the heart. And I'm going to show you some more images of that in just a few minutes, specific to the AFib procedure. But this is very precise technology that shows us where our catheters are in the heart and allows us to place these lesion sets around the pulmonary veins in a very specific way, in a very safe way. So this is an image. This is you're looking at a movie now of an atrial fibrillation, an actual atrial fibrillation ablation procedure. And as this runs, I'm going to orient you. What you're seeing here is what I was showing that was in color a minute ago. When we place catheters into that left upper chamber of the heart for the treatment of atrial fibrillation, the first thing that we're able to do is build out a model of the chamber that we're in. And here you're seeing the left atrium. It's sort of shaped and sized like a tennis ball. And you see these sort of little bunny ear looking features. Those are the pulmonary veins. And what you have to imagine is that's where the atrial fibrillation is originated. You see the ablation catheter with a green tip. This is actually showing you exactly where, or showing the operator exactly where the ablation catheter is within the chamber. And essentially what we're doing here, we're applying radio frequency energy, which is a titratable, very precisely controlled energy delivery system to sort of spot weld, if you will. What we're doing is we're creating point-by-point lesions. This would be a lot like if you were having a mole frozen or burned off your skin at the dermatologist office. And we're creating these lesions around the pulmonary veins that over the next several weeks after the ablation procedure will heal as a scar. And what's important to understand is that electricity can't pass through scar tissue. So we're creating this electrical dam of scar tissue around the pulmonary veins, thereby walling off this abnormal electrical activity that causes the atrial fibrillation. And in patients where we've identified the atrial fibrillation in its earlier stages, this eliminates atrial fibrillation statistically about 80% of the time with a single procedure. And this is what our final lesion set will typically look like. The pulmonary veins, you see here, this is a view on the left from the back side and on the right from the front side of the heart. This is what those lesion sets look like around the pulmonary veins. Normally patients have, humans have 4 pulmonary veins, 2 from each lung. Sometimes they coalesce, like you see in this case. The 2 veins on the left side of the heart come in and form a common left vein. The anatomy is a bit variable, but the lesion sets are typically very similar. We create these rims of scar tissue around the pulmonary veins, and that's what walls off that sort of rogue electrical activity. And this is a good example of a patient that I ablated just several months ago, who was in atrial fibrillation when he came into the laboratory. And just as we completed our lesion set around the right pulmonary veins, the patient went back into normal rhythm, but the vein stayed in atrial fibrillation. And let me orient you here. What you're looking at is what we're seeing on one of our computer screens. This is the electrical activity from our catheters that are inside the heart. And one of the catheters is in the right upper chamber of the heart, draped along the lateral wall, and you see those electrical signals in yellow. And you can see that those signals are marching along very nicely with a very regular cadence. There's some blue signals down at the bottom of your screen here that shows a catheter that's in a vein that runs underneath the left atrium called the coronary sinus. And you can see that that's running along with a very nice regular cadence. We call that normal sinus rhythm. But what you see in green is a circular catheter. I think you saw that on the previous movie. We call that our lasso catheter. And that catheter is in the pulmonary vein, in one of the pulmonary veins in this case. And you can see the chaotic, very rapid electrical activity that we're seeing from that catheter in the pulmonary vein. This is what AFib looks like. But as you can see here, this atrial fibrillation it's stuck in that pulmonary vein. It cannot invade the heart. We've disconnected that atrial fibrillation from the rest of the heart. This is exactly what Michel Hassaguer and his group saw when they first started doing the early ablation procedures back in the late 1990s and early 2000s. And it's always fun to see this. This is proof positive that in this patient, the atrial fibrillation was coming from this particular pulmonary vein. It's proof that that vein is electrically isolated and can no longer invade the heart. And this is the reason that atrial fibrillation ablation is so effective. I wanted to show this video for you. This is one more movie. Sometimes patients come back and they may have, or they may outright have, a sister arrhythmia to atrial fibrillation called atrial flutter. And atrial flutter is a looping short circuit. This was a patient who had his pulmonary veins electrically sealed. And I wanted to show you the level of technology. We can see in super slow motion the flow of electrical current through the heart. This was a rotating short circuit that we were able to eliminate. You can see this electrical activity, the color flow of this electrical activity funneling down the back wall of the left atrium here. And where you see that green dot was a single ablation site that terminated this looping short circuit. This was actually rotating about 250 times a minute. Again, this was in super slow motion that you see this, but this is the level of resolution that we get with these modern, what we call electroanatomical mapping systems. And in this patient, it allowed us to hone in very quickly on where this moving short circuit was rotating and apply a single lesion that eliminated this patient's arrhythmia after he had already had his atrial fibrillation taken care of. Looking forward, so we do a lot of atrial fibrillation ablation using the current techniques of, in our practice, radio frequency energy, applying heat to the tissue. Some practices use a balloon freezing technique to freeze the tissue in the pulmonary veins. But we do have to be mindful of the fact that with heating and freezing the tissue, There are some small risks to the procedure. You can potentially have collateral inflammation or injury to other structures, such as the esophagus or a phrenic nerve that goes to the diaphragm. And there are very rare complications of atrial fibrillation. I'll talk about that in a few minutes. But there's a very exciting new energy modality that, at least in theory and in current clinical trials, in fact, has shown that it only injures, and of course, that's what we're trying to do with ablation. We're intentionally injuring this rogue tissue in the pulmonary veins. This energy modality only injures the heart muscle tissue underneath the catheter. And what you see here is an example of what's called pulsed field ablation. Pulsed field ablation is probably the most exciting new technology to come to atrial fibrillation ablation. It's been in clinical trials in Europe now for several years, and it has not long ago been approved for clinical use in Europe. Here at Texas Cardiac Arrhythmia, I think we're in our 5th or 6th clinical trial of pulsed field ablation. Pulsed field ablation is not approved yet in the United States, but we're hopeful that it will be approved sometime in the next year or so by the FDA. What pulsed field ablation does is, rather than heating or freezing the tissue, it delivers a high energy, very, very short duration impulse to the tissue, almost like a shock. And that causes a disruption of the cell membrane of the heart muscle cells. So you have to imagine the heart muscle cells are sort of shaped like a boxcar, and they have a cell membrane. And what pulsed field ablation does is it disrupts that cell membrane transiently, and it causes the cell membrane underneath the catheter of that tissue to be leaky. And it causes a non-inflammatory cell death. We call it apoptosis. And we're able to be a little bit more aggressive in treating the tissue when we do heating or freezing techniques. We always have to be mindful of the fact that the esophagus is nearby, and there are other tissues that, in extremely rare incidences could be damaged. This allows us to ablate that tissue really with impunity, we think, and this is probably the way we'll be doing ablation when we look down the line over the next several years. So this is an exciting new energy modality, again, in clinical trials in the United States and pending FDA approval probably sometime in the next year or two. So let's talk about the ablation process. Here at Texas Cardiac Arrhythmia, I primarily practice at St. David's Medical Center in Austin. Our patients come into our center, beautiful center here at St. David's, the morning of the procedure. They come into what we call our day recovery area, or preoperative holding area, and they've remained on these. Our patients with atrial fibrillation have been on their blood thinners. We ask them to remain on their blood thinner, just not take it the morning of the procedure. And they come in and we have them meet with one of our anesthesiologists. Again, I think I mentioned that atrial fibrillation ablation is done with general anesthesia. An IV is put in, we check lab work, and then patients come back to our laboratories. And I wanted to give you a view of what one of the laboratories looks like. We have 6 laboratories, and the 7th coming here at St. David's. This is what the laboratory looks like. And you can see, I tell patients all the time, you're probably going to feel like you've been wheeled onto the bridge of the Starship Enterprise. This very advanced X-ray and ultrasound and computer equipment. And it looks a bit intimidating, but we have terrific staff that get our patients all set for the procedure. The anesthesiologist administers anesthesia, and patients sleep through the entire procedure, which typically takes about an hour and 15 minutes to an hour and a half in most cases. And while a patient's asleep, they're lying on this table that you see here. It's a padded table that you see there in gray. The operator, I would be standing on the front side of that table, or on the patient's right side, and looking at our big computer screens that are directly facing me. And we use those imaging modalities, as we talked about, to very precisely place our catheters and then do the ablation procedure. At the end of the procedure, all of the catheters come out. Those have gone up through the groin area. If you can imagine, the patient's completely draped, except for small areas right down around where the groin crease is. And on both sides, we use ultrasound guidance to place our catheters. They're like large IVs into the femoral vein. The veins are low pressure vessels. We place the catheters through those veins and then under X-ray and ultrasound guidance up to the heart. And then we do the ablation procedure. At the completion, those catheters come out, and we have sealing devices that seal the catheter entry sites right down in the groin area, deep under the skin, either a suture closure technique or a collagen plug, if you will. And patients then awaken from anesthesia, go to our recovery area, and spend an hour and a half or 2 hours down in the recovery area, just waking up slowly. And then come up to their hospital room. We typically keep our patients here at St. David's in the hospital overnight, just so that we can check on them the next morning and give them a complete discharge educational experience, and then send them home the following morning. There are some centers and some centers within the practice actually that send patients home the same day. And we just ask patients after the procedure to sort of take it easy for a week, not from a heart standpoint, but just to allow their groin area to heal up real well. We don't want them to lift anything heavier than 10 or 20 pounds and not do any real vigorous physical activity. From a heart standpoint, we don't have any restrictions whatsoever. And after a week, we tell patients to cut it loose. Go ahead and do usual vigorous activities, including exercise, and really no limitations after that. We do continue anticoagulation. We make a determination as to whether to continue arrhythmia drugs based on the chronicity of the atrial fibrillation and what we find during the course of the procedure. But most patients have stopped their antiarrhythmic drugs coming into the procedure if they've been on those, and only restart those if they have any recurrence. I should mention that about 15 or 20% of patients will have some arrhythmia as they go through the healing process after the ablation procedure. Again, we've created inflammation, sort of akin to if we branded a circle, let's say, on your forehand, you'd see a burn that gradually gets replaced by scar tissue. We've known for 20 years of doing this that a subset of patients will have some arrhythmia caused by that inflammatory response that will then go away as the inflammation resolves and the scar tissue forms. As opposed to, as far as risks of the procedure, it is an invasive procedure. There's no cardiac invasive procedure that's without risk, but the risk of any sort of a major complication, stroke, heart attack, death, 1 in multiple thousands. We're very cautious, as I mentioned earlier, around the esophagus. We have a temperature probe that allows us to monitor the temperature in the esophagus. If we have any heating of the esophagus, we can avoid those areas. But there have been reported cases of inflammation and even ulceration of the esophagus, but it's at a very low rate, probably 1 in 1,000. And it's not unusual to have some bruising down in the groin area after an ablation procedure, but any sort of a vascular complication, any significant bleeding is extremely rare. There's probably a 1 in 1,000 chance of fluid buildup around the heart during the course of the procedure that would cause us to have to put a tube in to drain fluid for 24 hours or so. But again, that's very rare. Post-procedure, we've become very mindful of trying to modify patients' lifestyles to try to give them the best chance of maintaining a normal rhythm going forward. And I think this is important to understand for any patient, whether they've had an ablation procedure or not. A recent study in Europe, a population study, has identified sort of a scoring system that you'll see here on this slide that will give us a pretty good idea of what the chances are of a patient having atrial fibrillation in the first place, and I think also is applicable to the post-ablation patient. You can see that probably the greatest risk of atrial fibrillation comes in our patients who have high blood pressure or hypertension. This is a point scoring system that assesses, based on the total number of points of these various factors, a level of risk. And as you can see here, hypertension has a point score of 4. Age greater than 65 is a risk factor. Elevated body mass index, so obesity, is a risk factor for AFib. It's not fair, but males have a higher rate of atrial fibrillation. Sleep apnea is an issue with atrial fibrillation. And we want patients, if they have sleep apnea, to have that sleep apnea appropriately treated, or if there's any suspicion of sleep apnea, to have a sleep study and have the appropriate management strategy, whether it's CPAP or an oral appliance applied there. Smoking is a risk for atrial fibrillation, and there are a lot of reasons to stop smoking, but one of them is that it increases risk of recurrent AFib. And then heavy alcohol use. And you can see down here on the sort of the bottom right, based on the scoring system, what the probability of remaining free of atrial fibrillation is. A low score, essentially those patients don't have any atrial fibrillation. If you have a score of 10 or greater, you can see that there's a very high risk of atrial fibrillation. So I'll stop there. I hope that this has been informative and given you a good framework for how we treat atrial fibrillation in the modern era. Ablation therapy has really been a godsend. It's probably the most rewarding treatment modality that I'm able to provide for patients. Here at Texas Cardiac Arrhythmia, we have a wealth of experience. We probably do 1,500 to 2,000 AFib ablations per year, and have wonderful results. Not everybody's fixed with atrial fibrillation. I think it's important to understand that. Some patients need the addition of drug therapy to their ablation procedure. The sooner, the earlier in the disease process we're able to intervene, the more likely we are to eliminate the AFib. So we like to catch atrial fibrillation when it's still paroxysmal, but that doesn't mean that we can't fix or at least modify and significantly improve the atrial fibrillation even when we catch it in the later stages, what we call persistent atrial fibrillation. And on that note, I think it's important to understand AFib does evolve over time. We really do want to try to catch it earlier. Apple Watches are a great modality to do that. It allows patients to see how much AFib they're having, and quite often patients self-refer when they've first had episodes of AFib. But when AFib has been allowed to be present for extended periods of time, understand that upper chamber heart muscle tissue outside of those pulmonary veins is beating at 300 times a minute or 350 times a minute. And that rapid electrical activity, I mean, imagine if you could work your bicep muscle 300 times a minute or any other muscle in your body. That's tremendous wear and tear on that heart muscle tissue. So we really want patients to be mindful of trying to have their AFib dealt with earlier rather than later in the disease process. And we preach this to our primary care physician and cardiology colleagues to try to get those patients to an electrophysiologist as soon as possible in the disease process to avoid that progression. Because the longer patients are in atrial fibrillation, the more electrically dysfunctional those upper chambers become. The muscle tissue, what should be normal muscle tissue outside of those pulmonary veins that we've been talking about, begins to develop patchy scar tissue. And that's where the horse can kind of get out of the barn on it. So if you have AFib or you think you have AFib, see your cardiologist, see your primary care doctor, get referred to an electrophysiologist, and let's start the ball rolling of fixing your atrial fibrillation. So that's all I have for you today. Look forward to seeing you again, hopefully on CardioVisual sometime soon. Joe Gallinghouse from Austin, Texas, signing off.